A very good morning, everyone. I am Dr. Shilpa Tarini, cornea faculty at LV Prasad Eye Institute, Visakhapatnam. Today, I'll be presenting a case where we retrieved a posteriorly dislocated desect lenticule, which was later on attached, and the graft was found to be functional at the end of 6 months. Desec in aphakic eyes and iris tissue loss is challenging because there is higher chance of dislocation into posterior segment due to lack of iris lens diaphragm. Lenticule detachment rates can be as high as 16.7% in complicated cases, and surgical removal of the posteriorly dislocated grafts and reattachment of the same graft is challenging. Here is a case of 72-year-old male with right eye brown cataract and left eye pseudophakia who underwent an eventful cataract surgery in right eye, and he landed up with aphakia, iris tissue loss, and a decimate detachment. He underwent desmetopexy 1 week later, but then 4 months later he presented with bullous keratopathy. So we decided to do a decimate stripping automated endothelial keratoplasty for this patient. But during the surgery, you can notice that there is aphakia and there is a lot of iris tissue loss. As soon as I implanted the lenticule, you can notice that just after injecting the air bubble, you can notice the graft slips down into the posterior segment. There was no chance to retrieve. The nightmare happened here. So finally, the patient was shown to a VR surgeon, and we plan to do a pars plana vitrectomy, desec lenticule explantation with the secondary scleral fixated IOL implantation. Desec was not planned at this visit because of the risk of high inflammation and graft failure at this if it is done at the same sitting. During the surgery, the graft was noted to be lying folded on the inferior retina. The graft was carefully unfolded, and with the help of a flute needle, it was brought out through the temporal scleral incision. As we noticed that the graft was looking viable and healthy, we plan to attach the same desec lenticule after performing the scleral fixated IOL. So the challenge here is how do you identify the correct orientation of the dislocated desec graft? What the few pointers are: curvature of the donor lenticule, the concavity of towards upper side indicates that the endothelium is on the upperward, and the convexity toward indicates the stromal side. The folded appearance of decimate membrane, the fine stromal fibers, staining of the stromal side of disc and stressed endothelium with trypan blue, gentian violet marking on the stromal side before implantation also will help you point towards identifying the correct orientation. As you can see, the below image shows after soaking in ringer lactate, the curvature takes up the normal curvature of the cornea, helping in identifying the orientation. One more tip is, in aphakic cases and iris tissue loss, always try to maintain a full chamber air bubble. Do not replace the air bubble with saline, because on change of posture, the air bubble tries to escape into the posterior segment. So coming back to our case, this case had good outcomes with nearly 20 best corrected visual acuity of 2160 at the end of 6 months. You can see that on diffuse and slit lamp image. The lenticule was compact, and the host stroma was compact, and the lenticule was well attached. This is supported by anterior segment OCT findings. At 6 months visit, the cornea is pretty compact. Looking at the literature review, there were few cases reported. Afshari et al. Reported 8 cases. Only in that case series, only one case had successful outcome where the lenticule was reattached at the same sitting. But in our case, we reattached 26 hours later. If you delay more than that, you can have inflammatory changes and the graft will not be viable. So in our case, the estimated endothelial cell loss at the end of 6 months was 71.3%. The normal expected endothelial cell loss in desec cases is 34 to 38% reported. Ours is more than twice of that reported previously. But when tissue availability is challenging, the same lenticule can be utilized for reattachment. But when you have a good tissue available, it is always a better choice to order a new tissue and use it for desec. So here are my takeaway points. Prompt retrieval and reattachment of drop desec may have good outcomes. Yeah, thank you.
Thank you. It was brave of you to use the same tissue, especially in an institute when tissue is available. I think, I don't know what the other eye status was. It aphakic? Because the choice of doing an aphakic desec, I'm not quite sure why you all made that decision. You could have had a planned SFIOL with a desec in the first sitting itself. But having said that, like let's say it's a one-eyed patient where you don't want to put an IOL and you want to leave an aphakic patient aphakic and do a desec. I think they've also reported where you can pass a suture through the stromal end of the disc and like use that so that you don't have a dislocation into the vitreous. So that is an important point which we can remember.
Yeah, suture pull-through technique can be adapted.
Yes,
Yeah.
that also helps. Otherwise, I would say it's a well-managed, bravely managed case. Thank you.
Thank you. Thank you.
So adventurous surgery, I would say, and
Yeah.
with very good results and good documentation. Are you considering publishing it, or it is already published?
Yeah, send to BMJ case reports. Yeah.
All the best.
Thank you.
Maybe
Thank
we
you.
can keep the sheet slides in before and inject the air bubble and wait for 10 minutes whether it is attaching and then remove the sheet slide.
Yeah, that's also a good suggestion.
Yeah. No, you can keep the sheet slides in, make a large bubble, give 10 minutes, it will attach and then remove the sheet slide.
A small bubble will work when there is iris. Here she also had aniridia. That's
Complete
why I feel
total,
that
near total
either
aniridia.
using an aniridia IOL or SFIOL would have been a better choice. I don't know what was the reason that was not decided. And if you don't want to do any of it, passing a suture I have done myself. It really works well. You have to keep the
Yes.
suture till you finished your case. Yeah.
Yeah.